Thank you very much. Reminds me I'm going to have to get a briefer biography. As Florian had alluded to in his talk, there is certainly chemotherapy treatments for leukemia, but stem cell transplantation continues to be the most curative therapy available for a wide range of blood malignancies. And I will give you a little bit of background. See if I can get this to advance. There we go. So this is the organ that we transplant, which is bone marrow stem cells. Historically, that was done through the collection of bone marrow in the operating room. But these days, by far, the most transplants are done using peripheral blood stem cells that are collected by leukapheresis. A little bit unlike a solid organ transplant, we have to give a preparative regimen to do a transplant, which is high-dose chemotherapy with or without radiation. The one shown here is not with radiation, but it takes about a week to deliver in hospital, and then the stem cells are given either bone marrow or peripheral blood. And then we have to ensure that we give graft versus host disease prophylaxis. Again, a little bit unlike solid organ transplant, we're trying to actually immunosuppress the graft because it can cause very big problems with transplant. First of all, it can cause acute graft versus host disease, which is something that they have struggled with going back to the first modern transplants in 1970. And it can cause a life-threatening and fatal reaction that generally involves, as shown here, the skin, the liver, and the gastrointestinal tract. Once you survive acute graft versus host disease and are discharged from hospital, you can unfortunately end up with a sort of an autoimmune-like condition called chronic graft versus host disease that can seriously influence quality of life, and people also die of this, largely due to infections that are related to the immunosuppression that is delivered as part of treatment of chronic graft versus host disease. And this is a little bit different, involving the eyes and the mouth, as well as the skin, both superficially, as shown there in the picture of the ankle, where you can get scaling and erythema and thickening and tightness, or you can end up with deep fascial involvement, as shown in the arm, where you get this puckering of the skin, as opposed to superficial changes. So unrelated transplants are what we often rely on with the decreasing family sizes over the last 20 years. So we have been doing many more unrelated transplants than related donor transplants over the last 20 years. The problem with transplants are not only can you relapse after transplant, but you can die of non-relapse mortality. And improving that has been our focus, and we have tried to optimize our conditioning over the past 20 years. We have certainly improved our supportive care and experience in looking after these patients. But what we also have been trying to do is optimize the selection of the unrelated donor, which is the focus of today's talk. And in choosing an unrelated donor, these are the considerations that we have to take in and collect data on, and I'll cover these a bit at a time. So in trying to decide what's best in selecting unrelated donors, I did a 10-year review with at least a 2-year follow-up of patients. So the period that I looked at is 2010 to 2019, and involved 427 unrelated donor transplants. And not to get into great detail, but just to highlight a few things, the patients, the median age of our patients was 53, but we've done unrelated donor transplants out to age 70. And over half of the patients have acute leukemia as their diagnosis. So there's a variety of other malignancies as well. And as I noted, peripheral blood stem cells are by far the most common these days over bone marrow. 95% of our transplants were done with blood stem cells in that 10-year period. And we have been using lighter conditioning regimens or preparative regimens, what we call reduced intensity regimens, which has allowed us to deliver transplants to older patients and those with other comorbidities. And about 3/4 of the patients had a traditional myeloablative transplant and 1/4 had reduced intensity. And this bar graph just shows you the transplant activity, with the blue bars being all transplants. The orange bars are the reduced intensity transplants. But over that decade that I've looked at, we've gone from doing somewhere around 30 to 40 transplants a year to 55 to 65 transplants a year. So certainly it's increasing in numbers. And what I'm going to look at is the donor characteristics today. And just to highlight a few perhaps interesting things, our average unrelated donor age is 28, but we have used patients as young as 17 in countries that allow that. BC or Canada is not one of those, and the age of 59. We do prefer males, so 82% were males, largely because females who have been pregnant are sensitized and will create more graft versus host disease, we believe. But we still do transplants with women that have been donors that have been pregnant. About 54% were nulliparous in the female population. We try to aim for a 10 out of 10 match, looking at the HLA A, B, C, DRB1, and DQB1 loci, and about 3/4 were matched at that. The other 1/4 were a 9 out of 10 match, so one locus mismatch. There was one that was a 2 locus mismatch. The ideal situation, because CMV has been such a problem in stem cell transplantation in the past, is to have a CMV negative donor and recipient. Unfortunately, only about 30% of the patients and donors are in that situation. And while it would be nice to have ABO compatibility, only about 40% of the donor recipient pairs are in fact ABO compatible. That's not a major barrier. We can use ABO incompatible donors without too much difficulty. And I'll show one just general slide outlining the outcomes. 5-year event-free survival for this 10-year period was almost 50%, which doesn't seem as high as we would like it to be, but in the days when I was a fellow back in 1990 and we were just beginning to do unrelated donor transplants, 25% was considered good. In terms of using fully ablative high-dose chemotherapy versus a reduced intensity transplant, the results are about the same. There have been some interesting trends in this non-relapse mortality versus relapse mortality in our population. The blue bars show the non-relapse mortality, which over those, I've divided up into 3 years, 3 years, and 4 years. The NRM has gone from 30% down to less than 20%, so it certainly is improving. Interestingly, the relapse rate has slowly been increasing over those 3 eras. The major complication of transplant, acute graft versus host disease, has been decreasing. Look at those same time periods from 69% in the first 3 years down to less than 50%. And one of the main reasons is that we're using in our conditioning regimen antithymocyte globulin, which was often a treatment for graft versus host disease in the past. Now we're using it as a prophylaxis. And you can see that almost 70% of patients in the last 4-year period were getting that as prophylaxis. Chronic graft versus host disease is very similar. It's gone down from somewhere around 75 to 80% of patients down to about 50% of patients in the last 4 years. And especially severe chronic graft versus host disease has gone down from a third of patients to less than 10%, which has made a big difference in survival. So how do we choose the best donor with regards to HLA compatibility? This has been looked at for decades, with A mismatches felt to be better than C mismatches. If we use bone marrow, since we use mostly peripheral blood, it's actually thought to be the opposite, C being better than A. And it's thought that maybe C allele mismatches are a little better than a C antigen mismatch. And this shows the results for our 10-year period. The very busy red curve is the 10 out of 10 matches. And above the red curve are the B mismatches and the DQ mismatches. In fact, DQ mismatches are as good as a 10 out of 10 match. B mismatch is also doing very well, but the ones that are below the average are the A mismatches and the C mismatches. If you divide it up by just saying, forget about the DQ mismatches, let's look at the 8 out of 8 matches versus 7 out of 8 matches. You can see the matches do better than the mismatches, although it's not statistically significant. Why do they do better? The blue bars show the non-relapse mortality, which is higher in the mismatches. But interestingly, there's this counterbalance, this teeter-totter double-edged sword phenomenon where the more GVHD you get, the less relapse you get. And in fact, the 7 out of 8 matches have a lower relapse rate, but it doesn't compensate for the higher acute graft versus host disease relapse, non-relapse mortality. When we looked at which loci caused the worst complications, the most graft versus host disease, C mismatches seem to cause the most acute graft versus host disease, but A mismatches actually cause the most severe acute graft versus host disease. That's grade 3 to 4, which is the orange bar, which has a mortality rate that approaches 90%. Chronic graft versus host disease is also worse in C mismatches, 81.3%. And the orange bar shows severe chronic, which is also worse in C mismatches. So to summarize, we've concluded from our data that B loci mismatches are probably the best. A and C are the next two. We don't do very many DRB1 loci. We recognize that it is the most important immunologic locus, and we don't do those if we can avoid it. We don't think that DQ mismatches warrant any consideration. And as I mentioned, the A mismatches seem to have more severe acute graft versus host disease, and C mismatches have more severe chronic graft versus host disease. What about donor gender and parity? Again, we have for years tended to choose male donors. And if we use a female donor, we prefer that they be non-sensitized, in other words, nulliparous. When you look at our results divided up by males and females, the curves are overlapping. So no difference by donor gender. Divided up a little more into the nulliparous donors and the pairs female donors, it's interesting the green curve that's on the top is actually the pairs female donors. So while nulliparous have been our favorite over pairs female, it doesn't seem to be backed by the results. There's a difference between the female recipients and the male recipients when we look at these donors. So in the female recipients, the nulliparous female donors are clearly running below the other two curves. Why is that? Well, it's not because they get less graft versus host disease, because this is the pairs female donors in the middle there. They 92% develop acute graft, 65% develop acute graft versus host disease, 92% develop chronic graft versus host disease, and 50% of those it's severe. So it doesn't sound like it's a very good choice. But when you look at the the nulliparous females, their acute graft-versus-host disease is less than even the male group, which is at 57%. And their chronic is very similar to the male group, and we have no nulliparous female donors that have caused severe chronic. So you'd think that'd be good, but it isn't when you look at relapse. So this is the relapse. So the pairs female donors with all of that acute and chronic graft-versus-host disease have a very low relapse rate. And the nulliparous female donors seem to have a very high relapse rate. In the male recipients, it's not quite the same. Again, the male donors are that big red line with all the events on it. The nulliparous female donors seem to do better in male recipients. So they are the high bar here. And we don't seem to see the same results with regards to acute and chronic graft-versus-host disease in the nulliparous female donors in male recipients. They have a very high, again, looking at the right-hand columns, they have a very high incidence of chronic graft-versus-host disease and significant severe chronic graft-versus-host disease. So it may be that there is a gender disparity effect here that causes the graft-versus-host disease, and it's not so much the parity of the donor. So we still tend to prefer male donors. They seem to cause the lowest acute and chronic graft-versus-host disease and non-relapse mortality, but pairs female donors may not be as bad as we had previously thought. And especially in female recipients, they seem to be associated with a lower relapse rate and a better survival. Donor age, the conventional wisdom, we always like to choose that 18-year-old donor from Germany. Germany has the largest unrelated donor and most highly developed unrelated donor registry. So 60% of our donors, unrelated donors, come from Germany. And they have a lot of 18-year-olds on their registry. Presumably this is because the adaptability of a young immune system going into a new body, it's much less willing to attack the body. So is using a young donor appropriate? Well, kind of, not quite. The red curve is the 18 to 30 ideal donor age group. The one that's running above it is actually the oldest group, the over 40s. And the one that's running below is the one in between. When you actually look at the figures of acute and chronic graft-versus-host disease, NRM, all of them do seem to follow that age pattern, and that is that acute GVHD goes up as the donor ages, including the over 40s, it's at the highest. The chronic graft-versus-host disease goes up and is highest in the over 40s. But somehow the relapse rate is lower in that over 40-year-old donor, and it results in the best survival. So not quite sure what to conclude when it comes to donor age. We probably still should continue to choose the youngest donors because that provides us with the best in terms of acute and chronic graft-versus-host disease and NRM, but event-free survival does not seem to be any better using a very young donor, and that we shouldn't get too tied up in choosing the youngest donor. CMV used to be the most difficult problem we dealt with after stem cell transplantation because people would develop CMV pneumonia and die quite frequently. So it would be best to try and keep the recipient CMV negative by using a CMV negative donor. Unfortunately, many times, more often than not, the recipient is already CMV positive at the time of transplant. Does it make a difference? Unfortunately not. So the red and the blue curve that are running there together are CMV negative recipients. with one being a CMV negative donor being used and the other being a CMV positive donor being used. So it doesn't seem to make a difference what you do with CMV negative patients. The two curves that run together on the bottom, more or less, at least until well beyond 5 years, are the CMV positive recipients. So again, it doesn't seem to matter what CMV status the donor is. If you're CMV positive, it doesn't matter. So I guess I went so fast. I guess the conclusion is that we really shouldn't pay any attention to the CMV status at this point. It is determined by the CMV status of the recipient, which has been established by the time they ever get to transplant. What about donor ABO type? There's a lot of concern in the 80s that using a ABO mismatch would lead to an inferior outcome, just because you'd think there'd be more stimulation of the immune system because of the ABO mismatch. That has never really been shown, but interestingly, when we started doing reduced intensity transplants, the minor mismatched ABO minor mismatches seem to experience more graft versus host disease. There's some debate whether that would lead to worse outcome, but that's what the studies have shown. What did we see? Well, the minor mismatches are the blue curve, and that is on the bottom. Again, the busy red curve is the ABO matched. The green one that's running almost on top of it is a major mismatch. And the major and minors are actually doing the best of all. Why is that? Well, we looked at the myeloablative and the reduced intensity transplants separately. And in myeloablative, these curves run completely together. It's in the RIC transplants where the minor mismatches do very poorly. So it is in RIC transplants, as the data would suggest, that there are some issues when you use minor mismatches. Why is that? Well, it seems to be because they have a higher relapse rate, not because there's more immune stimulation and more graft versus host disease. They have a higher relapse rate. And I don't know if I have a really good explanation for that, but that's what we found. So when it comes to ABO mismatches, for unclear reasons, in the RIC situation, you should avoid minor mismatches. So in this project, these are the conclusions that I came to after reviewing 10 years of data and pulling my hair out. That's why I had no hair. Really, we should be looking for 8 out of 8 matches, which is what we do right now. We're looking for 10 out of 10 matches, but I don't think we have to look at DQ. If we have to go for a mismatch, probably we know a B is preferred. When it comes to donor gender, we still prefer males, but we should not be too fussed about using pairs females because they may produce a little more GVH, but they produce a better survival, especially in female recipients. Young donors are probably a good idea. They certainly have the optimal GVHD NRM numbers, but there really are very minor differences when you start factoring in relapse risk when it comes to overall survival, regardless of the age of the donor. We don't need to look at CMV status, and we probably should avoid minor mismatches in reduced intensity transplants, although don't ask me why. And with that, I will stop my babbling and be more than happy to try and answer questions.
Tom, thank you very much. That is a huge body of work, actually, over those 10 years. Maybe I could ask you, in the last 10 years, say maybe a bit longer, there's been quite a lot of positive things said about haplo-identical transplants. Is it still the case, though, that for a patient without a matched sibling donor, you would go to a suitably matched unrelated donor, or does the possibility of a haplo transplant come into the equation as second line?
Yeah, so we've been doing haplo transplants, so half matches, which again opens up other siblings, parents, and children of patients for the past 7 years, and we've now done 50. I just reviewed the data last month. So we're getting a body of evidence on how effective that approach is. It's a lot cheaper. Getting unrelated cells is about $30,000 US. Germany gives it to us for cheaper, so that's another reason we like to use German donors. But haplos will cost $1,000 or $2,000 for the various workup and collection of cells. So it's a lot cheaper. And I would say that the results are improving and perhaps are close to 40%. But the follow-up's pretty short. A lot of those 50 have been done in the last year. And again, this data has, the median follow-up is, I don't know, seven or 8 years, but minimum of 2.5-year follow-up. So I think we have to be cautious about putting all of our ducks in or all of our eggs in the haplo basket, because it still needs a little more experience here. There is concern that it is going to lead to a higher relapse rate because, again, for those in the audience that don't know, special graft-versus-host disease prophylaxis is given to haplotransplants to the point that they have the lowest risk of GVH of any transplant we do. And that is, as you might guess from my data, is going to cause higher relapse rates. We just don't know how high and when. Do we need to follow them for 2, 3, or 4 years before deciding that the relapse is not going to occur? So I'd say to answer the question, Mike, I think we're getting there, but still I prefer unrelated donor transplants. I had to have done this for something.
Okay, thanks. Yes.
Oh, thank you for this nice talk. So I'm just wondering, have you tested the DP beta mismatch? Because now with the new NMDV donor selection criteria, they are actually prioritizing the DP beta mismatch over the DQ mismatch. And the other question is, have you also thought about the HLA-B leader sequence mismatch, which is the paper that got published a couple of years ago?
So first of all, the EBV question.
Yes.
So we do EBV testing on our patients and on recipients, or on our patients and on donors, but we have never used it as a criteria for choosing a donor. As you might imagine, 80 to 90% of both donors and recipients are EBV positive. So
they are positive, but sometimes are permissive versus non-permissive. Like they can be mismatched phenotypically, but they can be matched when you do this permissive, non-permissive mismatches using the tool, using the T-cell tool, which is present in the OMGT database or website.
Yeah, I don't know much about that whole area. I know that every time we introduce another criteria for selecting an unrelated donor, it makes it more and more complicated for us.
Yes, I agree.
The HLA lab did that nicely for us when they started their new sequencer, and they were providing us with a bunch of loci that we weren't familiar with looking at. And now we do start to consider those when we're selecting donors as well. So no, I don't know much about the EBV, using EBV as a selection criteria. The other one was with regards to...
The other one was about the HLA-B leader sequence mismatch, because I think there was a paper published a couple of years ago.
So HLA-D...
HLA-B leader sequence mismatch, which is in exon 1, I guess.
Looking at sequencing and that
yeah,
sort of
so
thing?
if you have like a methionine versus threonine, you get like some sort of mismatch, then this increases the graft versus host disease. Yeah. I think it was published by Dr. Effie Petersdorf.
Effie Petersdorf, yeah.
Yeah.
Yeah, no, again, there have been a number of those publications, and again, it's been so difficult. Sometimes it's very hard to find a donor, but it's been so difficult to choose donors on the data we have that we've been waiting for larger studies to show that sort of selection is warranted.
Thank you.